I will talk about the most important issue in implant treatment, the quantity and quality of the remaining bone. Whether it is AllonX or an implant-assisted partial denture, implants require sufficient bone support. If there is no bone, there is no choice but to use a removable denture. That is simply unavoidable. So when there is no bone, the removable denture must be done properly. Patients like this do come in. We placed implants where possible, and for the maxilla with severe bone resorption, we provided a removable full denture. This is the patient I mentioned earlier. After that, the patient insisted on placing implants even in the maxilla. It turned out the patient's office was located in the same building as my clinic, and the patient was also a very heavy smoker. That situation was clearly not ideal. Even though I repeatedly explained that maxillary implants would be risky, the patient insisted on proceeding, and then problems inevitably occurred. The implants failed, were replaced, and failed again. It became a very difficult situation. More than 10 years have passed since treatment began, and it still has not been completed. Normally, one might expect strong complaints or legal claims against the clinic. However, from the beginning, the patient was clearly informed about the high risk of implant failure. Still, the patient felt it was unacceptable to use a removable denture. The patient said they never realized how many delicious foods there were. That is why the patient strongly wanted implants in the maxilla as well. As a result, many implants failed in both the maxilla and mandible. When maxillary and mandibular implant prostheses occlude, masticatory force inevitably increases. Naturally, occlusal loading also increases. Consequently, the risk of maxillary implant failure increases, and mandibular implants are exposed to excessive loading, leading to complications. So when implants fail, they are replaced, and when they fail again, they are replaced again. Of course, additional costs are charged for reimplantation. It is also common to see cases with no bone in the posterior mandible. Even with a partial denture, patients chew only with the anterior teeth that still have occlusal support. As a result, the anterior teeth repeatedly fracture or are lost. That is when implant treatment is discussed again. I explained that implants must be placed in the posterior mandible to improve occlusal support. However, I also ask whether the patient accepts the risk of mandibular canal injury. Only if the patient acknowledges potential complications can implant placement be considered. If they do not accept that risk, implant treatment cannot proceed. There is simply no alternative. If you look at the maxilla as well, the bone around the posterior implants has significantly resorbed. This patient has been under my care for about 25 years. So I explained everything from the very beginning, because it was predictable that maintaining this occlusal condition would lead to problems. I explained that with maxillary implants and a removable mandibular posterior denture, severe mandibular bone resorption would occur. These discussions must happen when the treatment plan is first established. For example, imagine a close friend coming in for implant treatment. You would not proceed without explaining that long-term use of removable prostheses can result in severe bone loss. In fact, the treatment order should have been reversed. Implants should have been placed in the mandible and the removable prosthesis used in the maxilla. However, due to the circumstances at that time, this is how the situation developed. As you can see, implants have failed and disappeared in many areas. In the maxillary anterior region, there is almost no remaining bone. The outcome of implant treatment became disastrous. Now you can understand why Morse taper screw-type implants are avoided. Micromovement at the abutment connection can cause screw loosening and periimplantitis. For example, suppose this patient wants implant treatment again. Which abutment connection system should be selected? As I recall, this patient underwent full mouth rehabilitation using the S-Lock implant system with a locking taper abutment connection. This patient also presented in a similar condition. Almost all implants had failed. We performed AllonX in the mandible and removed all maxillary implants except the upper right second molar implant. An additional implant was placed on the opposite side and a removable denture was fabricated. This was an implant-supported overdenture. The patient did not want to remove the maxillary right second molar implant. At the same time, the patient requested full implant placement again. However, I told the patient that I could not proceed. Placing implants in the absence of residual bone carries a high failure rate during surgery, and after prosthetic delivery, increased occlusal loading during mastication greatly raises the risk of complications. If occlusal load exceeds occlusal support, implants will inevitably fail. Therefore, I recommended placing a symmetrical implant on the opposite side to create an implant-supported overdenture. If implant support exists on only one side, the overdenture support becomes asymmetrical. With uneven bilateral support in an implant-supported overdenture, the removable denture becomes unstable. You understand what I mean? You need to calculate these factors mentally when planning treatment. Symmetrical support is critical for removable dentures. So in the mandible, failing implants were removed and salvageable implants were maintained. Additional implants were placed and an AllonX cement-retained prosthesis was fabricated. The maxilla was then finalized with an implant-supported overdenture. Situations like this are frustrating. In such cases, anterior implants combined with an implant-assisted partial denture posteriorly would be appropriate. Patients often ask, why not make the entire prosthesis removable? But a fully removable denture lacks retention and support. That makes it extremely uncomfortable to use. Patients somehow manage to tolerate maxillary removable dentures. Most patients eventually adapt to a maxillary removable denture. However, mandibular removable dentures are difficult to adapt to, so anterior implant prostheses combined with posterior removable prostheses are often necessary. A combined treatment approach is therefore appropriate. In general, the maxilla is treated with a removable denture. Placing implants in the maxilla while using a removable denture in the mandible creates even greater problems. Because maxillary implant treatment increases occlusal force, increased maxillary support places more pressure on the mandible. Even if there is sufficient bone in the maxilla, implants are avoided in these cases. Having bone does not automatically mean implants should be placed. In other words, removable dentures in both arches may be preferable. If implants are placed, the mandible is the appropriate choice. That is how you should think about it. Ultimately, implant fixed prostheses and removable prostheses are fundamentally different concepts. For this reason, mandibular anterior regions should be considered first-choice candidates for implant fixed prostheses. What is favorable these days? In Korea, implants are covered by national insurance. For patients over 65, 2 implants and a removable prosthesis are covered. Although conditions apply, coverage for up to 4 implants would allow broader treatment options. Because 2 implants are subsidized by insurance, many patients agree to combine treatments. 2 implants are covered by insurance, and 2 are paid for by the patient. Ideally, placing around 6 implants provides even better outcomes. In my judgment, placing about 6 implants in the mandibular anterior and premolar regions allows implant treatment that can be maintained throughout the patient's lifetime. That changes everything. Implant treatments that fail quickly should never be performed. If function can be maintained during the patient's lifetime through maintenance, repair, or retreatment, the implant treatment is successful. Patients generally agree with the doctor's explanation. If not, why would an intelligent patient trust that doctor? They simply would not. In that sense, implant-assisted partial dentures may be an unavoidable choice. Think about it. Is an implant-assisted partial denture covered by insurance or not? It is covered. Up to 2 implants are covered, and maxillary full dentures are also insured. With just 2 additional mandibular implants, an implant-assisted partial denture can be made, so why not choose that option? Initially, I placed 2 implants in the mandibular anterior region and fabricated an overdenture. This was done using denture attachments. However, the peri-implant bone gradually resorbed. The overdenture retention clips are repeatedly engaged and disengaged. This repeated insertion and removal creates mobility at the abutment. With screw-retained abutment connections that are not locking taper types, screws tend to loosen during this process. Because denture attachment clips engage the abutment structure, repeated insertion and removal apply loosening forces to the abutment screws. Over time, peri-implantitis repeatedly develops around the implants. When I attended a Straumann implant seminar in the past, they presented outcomes of mandibular 2-implant overdenture treatments. With a 5-year follow-up, success rates were only around 70–80%. That means 20–30% of implant overdenture cases failed. Only in Korea do people claim a 99% implant success rate. Internationally, that is not the case. They are more honest. Treatment outcomes are acknowledged through statistics and data. That made me realize this type of implant treatment should be avoided. I began to think that placing 4 implants might be a better solution. If 4 implants are placed, what should be done? An I-bar type overdenture is appropriate. Connecting the abutments with an I-bar and fabricating an overdenture proved more durable, because the implants are splinted together with the I-bar. As a result, screw loosening is reduced. I have experienced many issues in the past using screw-retained implants. That is why I perform many I-bar overdentures. Even today, do you know what is used as an alternative to AllonX with multi-unit abutments? I-bar systems. Either implant-retained I-bar overdentures or fully bone-anchored prostheses connected to an I-bar are used, because multi-unit abutments used in AllonX are often unstable. In contrast, the design of S-Lock implant multi-unit abutments shows excellent connection geometry. If you look at many AllonX designs online, you will see many multi-unit abutments that appear questionable if screws do not loosen. Especially designs lacking anti-rotation features cause significant problems. They are essentially designed to loosen. Poor fit between the AllonX prosthesis and abutment leads to even greater issues. If the prosthesis does not fit precisely, it will move during function. That movement causes screws to loosen even more easily. Experienced clinicians therefore plan treatment differently. They prefer fabricating a bar-type structure to rigidly fix the abutments, then connecting the prosthesis using an internal I-bar attachment design. That line of thinking emerges. So think about it. If 4 anterior implants are placed, what should be done? An I-bar overdenture is the logical choice. It offers far greater advantages. Using an I-bar with only 2 implants is somewhat unstable, because splinting only 2 implants results in a short bar span. That leads to frequent problems at the I-bar clip. With 4 implants, the bar length becomes sufficient, and implant support is much better. That is why I-bar overdentures are commonly used. The same applies today. However, if 6 implants are placed, I would not choose I-bar overdentures or locator-based overdentures. Screw-retained implants without locking taper connections have a higher risk of screw loosening. And do you know what is most frustrating? Patients return every 6 months complaining, because retention clips contain plastic or elastic components. Those plastic components wear out and must be replaced every 6 months. This is not shoe repair. You do not replace shoe heels indefinitely, do you? And this has to be done free of charge. At least shoe repair charges a fee. What can you even do? After doing several cases, I realized this was not something I should continue. It was a moment of realization. So I stopped using locator abutment overdentures. I absolutely do not use them. Components must constantly be replaced, and patients expect it for free. So they complain every time they visit. They question why the treatment was done this way. Honestly, the patient is not wrong. That is why this kind of treatment is not sustainable. Ultimately, I-bar overdentures were the only viable option. But while doing I-bar overdentures, I began to think further. I realized it would be better to fabricate implant-fixed prostheses and combine them with implant-assisted partial dentures. This scenario is also worth considering. Imagine an elderly couple receiving implant treatment. If the denture is removed and an I-bar is visible, what happens? At least visible teeth look better. Even having teeth on one side improves appearance. Patients immediately understand when you explain it this way. They remove their dentures at night to sleep. I actually tell them to sleep with the denture in. Why is that? If a removable denture has no resin porosity, food does not adhere, odors do not develop, and deformation rarely occurs. Sleeping with the denture in is appropriate. However, if a denture contains resin porosities, sleeping with it causes strong odors due to trapped debris. Food debris trapped in resin porosities decomposes. That is why people soak dentures overnight in cleansers, but this becomes unnecessary. With non-porous resin dentures, patients are advised to sleep with them. Sleeping with the denture allows swallowing during sleep, while sleeping. Swallowing becomes easier and sleep quality improves. Why do elderly patients have trouble sleeping? Because they cannot swallow saliva during sleep. Try swallowing right now. If you cannot bite in centric occlusion with maximum intercuspation, swallowing becomes difficult. They simply cannot swallow. When biting and swallowing, the mandible retrudes and retrusive guidance is engaged. Retrusive guidance occurs due to posterior holding cusp interference. That is when the swallowing action occurs. In actual practice, some patients say they cannot eat after dental treatment. Why can they not eat? Because they cannot swallow. Retrusive guidance is not engaged. They can chew the food. But what must happen next? They must swallow. They must swallow. Without maximum intercuspation and centric relation, retrusive guidance does not occur, and food cannot be swallowed. The patient complains, the clinician does not understand why, and assumes the patient is the problem. Is the patient really the problem? Of course not. The treatment is at fault. That should never happen. The patient cannot be the problem, and you can easily tell if a patient is lying. If you cannot, then it is a lack of experience. Ultimately, it makes sense that dentures should be worn during sleep, right? And having anterior teeth visible when dentures are removed is far better. That made me rethink everything. Why not use fixed implant prostheses in the anterior region instead of locator or eye-bar attachments? That was my conclusion. From then on, anterior implants were restored as fixed prostheses using the surveyed crown concept. With just 4 implants, fixed prostheses can extend to the canines, and the partial denture can be used posteriorly. Over time, implant-assisted partial dentures began to be widely promoted. That was because I strongly disliked eye-bar overdentures and locator systems. Overdentures using eye-bar or locator attachments are extremely difficult to maintain. Aesthetically and functionally, implant-assisted partial dentures are far superior. You expect patients to be grateful after treatment, right? Even though treatment has a cost, restoring function and aesthetics should earn appreciation. But dissatisfaction with treatment outcomes creates difficult situations. Patients return repeatedly when results do not last. They come back with repeated periimplantitis and inflammation. Eventually, a good doctor-patient relationship cannot be maintained. So what can you say to the patient then? When bone loss and inflammation are clearly progressing, you lose professional authority. To put it bluntly, it undermines credibility. Ultimately, I simply did not like that situation, so I searched for a better alternative. That is how implant-assisted partial dentures became my choice. Because placing implants everywhere is often impossible. Sometimes implants cannot be placed in the posterior mandible, and the maxilla can be managed with a removable denture. Ultimately, implant-assisted partial dentures became a practical and reasonable treatment alternative.